Welcome to Link Paris 2025. I am Dr. Daniel Vela-Duarte, neurointerventionalist in South Florida, West Palm Beach. I have the pleasure of being with Dr. Raul Nogueira, who needs no further introduction. He's a neurointerventionist at University of Pittsburgh, endowed professor of neurology and neurosurgery at University of Pittsburgh Medical Center. And we have him here to discuss the results of the SUMMIT Max trial. The study was finalized, the enrollment was finalized in February, enrolling approximately 250 patients. The results were presented recently at the European Stroke Conference by Dr. Davuz and Dr. Tan Nguyen. And Raul, pleasure to have you here again.
Thank you, Daniel. It's a pleasure to be here on behalf of the SUMMIT Max investigators. It was a real pleasure to be part of this trial and work with our colleagues in this important project, which is one of the next revolutions in thrombectomy. It's the megabore catheters. So we have now had 2 trials conclude with 088 catheters. SUMMIT Max, it's actually a very important trial in terms of scientific methodology. It's only the 4th trial in terms of a device trial to opt for a randomized control trial after the SWIFT and TRIVO2 trial all the way back in Lancet 2012, and then the more recent PROS trial. What happened there is we randomized a total of 250 patients to either treatment with the Route 92 system or with the Vecta 74, which was the FDA choice based on the largest aspiration catheter available in the market for a comparison. So out of these 250 patients that were randomized, 166 were treated with the device and met all the exclusion criteria. So you're calling that the modified intention to treat analysis, which is the target population for our efficacy analysis. In summary, what the study demonstrates is that the Route 92 system with the HiPoint 88 aspiration catheter was no inferior to the Vecta 74 catheter in terms of achieving reperfusion TK2B or 3 without any rescue therapy. But more importantly, we could actually achieve statistically significant higher first pass full reperfusion, meaning ETK2C and 3, with 47% with the HiPoint 88 versus 31% in the Vecta 74 system.
This new system has clearly entered the innovation part of what stroke care is in the last couple of years. There has been tremendous development in catheters, and now we're entering an era of super large bore catheters. What is going to be the future of these devices, and how is this trial, what does it make it different from the previous studies that you just mentioned?
I think we are hopefully entering as you said, a new era, a new inflection point in thrombectomy, right? So we started with intra-arterial thrombolytics, we moved to the coil retriever, to the MERS retriever, then small aspiration catheters with the penumbra system. Then you had, I think, the big inflection point was the stent retriever technology. And since that point, the aspiration catheters been getting bigger and bigger. And we call them, Daniel, large bore catheters, but that's actually a misnomer, okay? Those catheters up to 0.7 or even 0.74, they are not large. If you think about the cross-section of the M1 artery, okay, and you compare, let's say, a 0.70 catheter, you are actually 2 to 2.5 times less cross-section area with the catheter than with the clot. So you actually have to shrink that clot 2 to 2.5 times the cross-section area in order to ingest the clot. So I think that the first point, the large bore catheters, they are not large enough. And they are actually, I would say, medium bore catheters. Okay. But in any case, because you had to say something was larger than large, it's now mega or super. And what you have now is, at least for the cross section of the MCA, you have something that more closely approaches the size of the MCA vessel. Two things happen when you do that. One is you block flow. So you have flow control, which is very important because when you have these smaller catheters and you start to reestablish flow, you have flow going through the side of the catheter and you wash clot and you have distal embolization. Also, it's hard to reduce the size of the clot to the size of the catheter. You need a lot of force to do that, okay? And these catheters don't have enough force. So if you go to the physics of aspiration, there are two very important reasons why megabore catheters are so promising. The first is the obvious one, right? So force, aspiration force, is a function of pressure, which is essentially the vacuum, the suction you have. That's a constant, right? But also area, the cross-section area. Obviously, the biggest that cross-section area is at the tip, the higher is your force.
You're getting into these very, very interesting technical details that it takes a little bit of science and engineering to understand. But what is, and we were discussing the delta pressure of what it takes the catheter, what it takes to the system to be in the MCA at the M1 segment. And so how is this monopoint system different, and how is the approach, how is the whole setup? Can you walk us through that?
Yes, so again, the advantage of having the large catheter, right, as you were saying, is with the larger cross-section area, you have higher aspiration force. But there is another point that it's very important that you understand. Not only you generate less force, but you need less force to ingest the clot. So let's get like the tower as an example.
That's our clot.
Okay, that's a clot. There is something called the stress-strain curve, okay? So stress is essentially force per unit area, and strain is the deformity of a solid. Very much like this towel. You require very little stress to deform in the beginning, but as it gets smaller and smaller, to get additional deformity and strain, you require a lot more force. So it's very easy to do this. And it becomes harder as it gets smaller. A clot has kind of this the stress-strain curve, okay? So think about it. When you have the big catheter, you just need a little bit of stress to strain enough to get here. When you have a smaller catheter, you need a lot of stress to strain it enough to fit in that catheter and be ingested. The problem is the bigger catheter has a lot of force. The smaller catheter doesn't. So it's actually, that's why when you look at this, it's an exponential chance of ingesting the clot. Is you generate more force, but you also need less force to ingest the clot.
To ingest it.
So that's the beauty of the 088 systems in general.
So the system of an 088 catheter has been compared to what it was best available at that time when the study initiated, an 074. Tell us about the safety of the study and why is this something that we could highlight?
I think that's a key point. So if you ask me, in general, you have now had two studies, one randomized, and you had the imperative trial, which was a single arm trial. I think the results are very good, they are very robust, but I don't think they have shown what I was expecting in terms of efficacy. They are definitely amongst the best device results you've seen, but I was expecting one step above that. At the same time, the safety. Many people had concerns about the safety of this approach. Oh,
it's a big catheter in the M1.
Catheter in the M1.
Right.
It actually, the symptomatic intracranial hemorrhage with the HiPoint system was 3.6%, which is actually less than what you saw, let's say, in the Hermes meta-analysis. Right? In the imperative trial, the same thing, was like less than 2%. So we think that same low ballpark of single percent digits, and if anything, numerical lower than what you have seen. So it appears to be very safe. That's also consistent with the observational studies that you had.
Very low rate of hemorrhagic complications.
Very low rate. very low rate. And in terms of efficacy, I still have hope that with additional studies, we're gonna show a much higher rate of first pass reperfusion with these systems. In fact, there is a subgroup analysis in Summit Max where they get the more experienced centers, like the 3 top centers, and that number went from the overall 47% FP all the way to close to 70%, I believe 68%. Right? So I think with more experience, more cases, we will get there. I also feel that the results will probably be better in the M1 than in ICA for obvious reasons with this particular type of device. But I think we're going to need additional studies. There is a third trial with a different system coming up soon. But I think in general, 088 should be the next inflection point in thrombectomy following the stent-driven inflection point you had over a decade ago now.
So the study was presented at the European Stroke Conference in Helsinki recently. The results are already published in the Stroke Journal. There is a third study that you mentioned is coming out soon. Where do we go from here? What's the next step in this type of technology, in this type of innovation? Do you think this type of devices are going to be the next standard to compare further and future technology?
I believe so. As I said, I think you're looking at the new inflection points. If you look at the things that are particularly promising in our field now, I would say the super bore, mega bore catheters, cyclic aspiration, right? And potentially some of the more novel stent retriever designs. I think those are and also techniques like dual stent retriever, rescue stenting, where the super bore catheter is gonna be in the hierarchy of the performance. We need more studies to evaluate
Maybe a
that.
combination of the Twin to Win and the Submit Max trials.
Yeah, I think when I look at the double stent, the way I look at this, I think you have a first line technique, right, which will likely be something like a super bore catheter or cyclic aspiration or a combination of both. People ask me, who you think who's gonna win, cyclic aspiration, super bore? I go like,
Maybe
okay,
the combination.
A V8 engine is better than a V6 engine, but a V6 turbo engine is just as good as a V8
Dual
engine,
turbo.
right? So I think adding these things will get us a synergistic effect. I don't think they compete, they likely complement. How the stent retriever based approach will be in relation to these augmented aspirations, you don't know now. But I think the dual stent retriever will be the ideal technique for rescuing branch type of occlusions, like in bifurcation points, versus rescue stent, probably more like the truncal type occlusions that are not in bifurcation points. So I look at these things as first line techniques, then second line technique, then bail line technique. And I really think that given data like what we've seen in Summit Max, having the overall safety of this, I think this will be towards the top first line technique in the future.
Well, Raul, thank you so much. It's again a pleasure. Always, you're always teaching us so much, and every conversation we have in each of these versions is so enriching and enlightening. So,
thank you
very much again.
It's a pleasure.
Thank you.
Thank you.